Good afternoon, everybody, and welcome to the Melanoma Research Foundation's third session of our Ask the Expert session with Castle Biosciences. We're really excited to be partnering with them and every Tuesday during the month of April to continue to cover a variety of topics related to melanoma diagnosis and treatment. My name is Lauren Johnston, Senior Patient Engagement Officer with the MRF. This afternoon, we're joined with Dr. Shannon Trotter, who will be conducting a presentation about the use of gene expression profiling, or GEP, in melanoma prognosis. First, I'd love to just highlight our partners, Castle Biosciences, who, again, as I mentioned, is hosting this month's series. Castle Biosciences is an innovator in diagnostic and prognostic tests for dermatologic cancer. Castle is also a skin cancer diagnostics company providing personalized genomic information to improve cancer treatment decisions. Their team is focused on providing physicians and their patients with personalized, clinically actionable genomic information to make more accurate treatment decisions. Castle currently offers tests for patients with cutaneous melanoma along with cutaneous squamous cell carcinoma, suspicious pigmented lesions, and uveal melanoma. Castle also has active research and development programs for tests in other dermatologic diseases with high clinical need. Castle and the MRF know that education is critical for patients and caregivers and their loved ones, making informed decisions about their care. This is why this partnership, hosting the Ask the Expert series, is vital to touch on topics to help educate and empower the melanoma community. If you missed our previous two sessions, which were focused on the melanoma patient's journey and the familial versus tumor genetics, they're both available to view on our Facebook page and YouTube pages. Before we begin the presentation, please know that we encourage people to use the comments section to ask questions, which will be addressed at the end of today's presentation, or we can follow up by following up with our presenter, Dr. Trotter, and making sure that all of your questions are answered on our Facebook page. The information presented during today's session is for educational purposes only. So any specific treatment questions you have always needs to be directed to your healthcare provider first. And now it is my pleasure to introduce our speaker, Dr. Shannon Trotter. Dr. Trotter earned a bachelor's degree in biology with a minor in psychology from the University of Dayton in Dayton, Ohio. She graduated medical school from Ohio University Heritage College of Osteopathic Medicine in 2006, and then completed a dermatology residency at Oblinus Memorial Hospital, where she served as chief resident. After residency, Dr. Trotter completed a fellowship in cutaneous oncology at Boston University and acted as director of the Pigmented Lesion Clinic at The Ohio State University. She is currently in private practice with Dermatologists of Central States and the Associate Program Director for the OhioHealth Dermatology Residency Program in Columbus, Ohio. Dr. Trotter is also an assistant clinical professor at Ohio University Heritage College of Osteopathic Medicine. Dr. Trotter has several clinical interests, including prevention, detection, and treatment of skin cancer and health policy and advocacy. She's a past president of the Ohio Dermatological Association and served on the American Academy of Dermatology State Society Relationships Committee. Dr. Trotter, it is just such an honor to have you here today to speak to our community.
Thank you, Lauren, for that introduction. I'm going to go ahead and get started with our presentation for today and share my screen with everyone. And it's really an honor to be here to talk about melanoma and skin cancer, especially with melanoma and the impact it's had on so many of my patients. It's really an exciting time because gene expression profiling is something that's really going to change the game, I believe, for our melanoma patients. And we're seeing that already. I tell everyone and my patients, we sort of live in this day of customization, just as simple as you can walk into a coffee shop and look at the menu and pick an order. You want maybe a latte, and you can look and you can pick the type of milk you want. You can get soy milk, you can get almond milk, traditional whole milk, skim milk. You can actually add syrup to it. You can even dictate the temperature that you want for your milk or for your latte, and they label it and give it right to you. So it's customized just for you. And that's really what we're seeing with cancer care. And now melanoma is no exception. So we'll talk more about gene expression profiling, My Melanoma Personalized, and really discuss the value that that offers for melanoma patients. Now, I do want to quickly disclose that I do have affiliations with Castle Biosciences that is sponsoring today's event with the Melanoma Research Foundation. I serve on their Speakers Bureau. I also have been a consultant and received research support. Now, for the goals for today, I really want this to be more of a conversation, just simply flow, just like I was sitting down and talking with you as if I was doing so with one of my patients. This is really meant to be more of an education on what is gene expression profiling, what is its role in melanoma, and how is it really changing things for the melanoma patient. Now, we do have to dive a little bit into the scientific piece. So you will see me comment a little bit on the difference between genetics and genomics, or gene expression profiling. And Dr. Moody really helped with that. He really teed us up for this talk. So we won't spend too much time there, but it's important to have that background before we talk more about gene expression profiling. Now, we will talk about the value of it in the melanoma patient. And then finally, I'll actually demonstrate how it can change management. Because if you think about it, we really don't want to be offering tests or treatments if they really don't change things for our patients. And what we've seen now with gene expression profiling in melanoma, it's actually changing our patients' management. And we'll use a case study to really just show that to you. Now let's go into a little bit with the genetics versus genomics. And again, we're not going to spend too much time on all the scientific aspect, but really this background again is important as sort of the foundation for our conversation today. Now, you heard a talk with Dr. Moody talking about genetics, familial genetics, and genetic testing. So just kind of cap on what he talked about. Genes, what are they? Well, that's what we inherit from our parents. They're passed down from generation to generation. And genetic testing specifically is looking at the function or makeup of one gene. And you may have heard of this before, especially even before Dr. Moody's talk, that we may consider genetic testing sometimes for melanoma patients. And there's different reasons why we might do that. In particular, the gene CDKN2A is probably the one that many of you are quite familiar with in regard to melanoma. Now, if we take that bridge from genetics and now look at genomics or gene expression profiling, really what is that? Well, that's really looking at the behavior of the genes that get passed down from your parents and explain something that we like to call tumor biology. A lot of people ask, well, what do you mean by that? What's tumor biology? Well, that's basically in regard to melanoma, looking at your melanoma and sort of making a prediction on how it might behave. Will potentially be more aggressive or more likely to recur or spread? Or if you are eligible or thinking about sentinel node biopsy, what's the likelihood of having a positive sentinel node biopsy based on the tumor biology or behavior of your melanoma? Gene expression profiling also offers us prognostic information. So the most famous prognosticator of all time, as you may know, is Puxatawny Phil. I've actually been to visit him and made the pilgrimage myself to celebrate Groundhog Day. And you know how Puxatawny Phil makes that prediction. Are we going to have 6 more weeks of winter or potentially an early spring? Gene expression profiling is also used as a prognosticator. It tries to help make that prediction of what is the likelihood of recurrence or metastasis or spread, and also what is the likelihood of having a positive sentinel lymph node. And then there are several available gene expression profile tests for different types of cancer. What you may not realize, this really isn't a new thing for cancer management. It's just a newer thing for melanoma. Probably the one cancer most of you are familiar with is breast cancer. Gene expression profiling is a part of breast cancer management. So now it's really exciting for us to have gene expression profiling for melanoma so we can use it to help our patients. So in gene expression profiling for melanoma, now that we get a little more specific, what is it really doing? Well, again, it's looking at your individual melanoma. Just like we talked about customizing that latte just for you, gene expression profiling really looks at your melanoma. Because what we've learned over time is not all melanomas are created equal. Now, we do have staging where when you're diagnosed with a melanoma, you're put into a particular stage. And we kind of call that sort of a population evaluation, where we put people together, patients with melanoma that have similar characteristics, into groups, because that then helps us decide what are we going to do next? What are we going to do next for treatment and then management and follow-up? The downside is that what we've realized is not everyone behaves like their stage says they should. So gene expression profiling really helps us sort of pull that out and sort of, define your melanoma a little bit more and make it more unique to you. It individualizes it. And we'll talk about that with a nice example just coming up. Now, it also describes your melanoma's biologic behavior. And I touched on that briefly with that whole concept of tumor biology, sort of trying to figure out, well, is my melanoma, going to behave like my stage says it should, or potentially is my melanoma going to be more aggressive? Gene expression profiling can help answer that question. And then it also helps with predicting, again, likelihood of recurrence or metastasis, as well as the likelihood of having a positive sentinel lymph node, and then finally guides those management decisions. So I'm going to break this down a little bit and bring it together, but I always like to use a few examples or analogies. Again, just as if we were sitting in my office or I was talking with a patient, trying to give them a better understanding of how gene expression profiling can really work for them and be a part of their melanoma management. So M. Taylor, full disclosure, this is a company that I have no relationship with. I actually just heard it on an ad on the radio. And I thought, this is a good idea. Now, what is it? Well, you can see in the name, M. Taylor, the word tailor. We all think of tailor being a wonderful thing. We don't often go anymore because it's expensive, but where you can truly tailor something for you. And what they are is a clothing company. And they offer custom fit jeans, guaranteed to fit, because they offer individual measurements of your body to make sure if you order a pair of jeans, it fits perfect in your waist, it fits perfect in your hips and your thighs, and the length is perfect. And what I like about this company from an analogy standpoint, they show how it can be customized to make things work for you, in particular with clothes. Because we all know you can buy off the rack, a small, a medium or large, but how many of us pick up a large and it's too big, but the medium is too small and you're somewhere sort of in between? Now, with melanoma management, this is where you have gene expression profiling. It can work in a similar way that M. Taylor does for clothes. Gene expression profiling can further define your melanoma that's unique to you. It individualizes it to you. Just like M. Taylor has been successful in individualizing or custom fitting clothes for their patient or for their clients. So it's one of those things that I think is really exciting, that we can now have gene expression profiling to really define your melanoma as it's unique to you. Because again, not all melanomas are created equal. So we just kind of saw how M. Taylor really works, to customize fit for clothing. And in the same way, gene expression profiling can really customize your melanoma for you, give you more information about how your melanoma is unique to you. Now, in addition to kind of that individual risk or information, we also talked about gene expression profiling being important to describe biological behavior. So this is an analogy that I like to give my patients, that if you look here at the screen, you see two pictures of a lioness. You see a lioness that looks quite angry and aggressive, and you see another one that appears to be quite friendly and docile. And the question is, when you kind of look at a lioness, you kind of favor, that's a pretty aggressive animal. But the question is, how do you know? How do you know if this is going to be for sure a lioness that might attack versus one that might be friendly? You want to know, what is the likelihood of that behavior? But we can agree, on face value, it's a lioness. Now we look at a melanoma, we can agree when we get a diagnosis back, it's a melanoma. But in our mind, we also want to think, well, what's the likelihood of this melanoma being aggressive, like the aggressive lioness? Or what's the likelihood of this melanoma potentially being more friendly or having, low risk behavior? And that's what I always tell my patients. That's sort of the concept of biologic behavior when you look at melanoma and trying to make a prediction. Gene expression profiling can help us to predict whether or not a melanoma potentially is going to be more aggressive, like the aggressive lioness, or potentially be a little bit more friendly, like the lion here. And in terms of the 31 gene expression profile test, we think of that as high risk, if it's going to be potentially more aggressive for spread or the likelihood of having a positive lymph node. Or we think of it as being low risk, if that risk is low for the likelihood of spread, or low risk for the likelihood of having a positive sentinel lymph node. So I think this analogy really helps kind of hit home the message of what gene expression profiling can help us do. Now, in regard to that, it's really looking at that recurrence risk, again, the likelihood of having a positive sentinel lymph node. And then in essence, when you get sort of that risk assessment back, if you're at high risk or low risk, then the unique part is we can really tailor your management to you. Because somebody who potentially is a low risk patient for spread or metastasis, or a low risk for sentinel node biopsy, that may change how they're managed. And for somebody who's a high risk, we might be more aggressive potentially with their management. And what do I mean by that? Well, it's kind of important to touch on just, well, what is the concept of risk? I think we all have different ideas of what truly risk may mean. But in terms of gene expression profiling, I'm using it in terms of the likelihood of something happening. And in particular, we're looking at the likelihood of spread and metastasis and recurrence. And we're also looking at the likelihood of a positive sentinel lymph node. Now, the best analogy I can give you for everyday assessment of risk is when we watch the news each morning. Many of you probably watch and look to see what's the weather going to be? What's the risk or the likelihood that it's going to rain today? And if you think about it, it impacts your decision as to how you move forward with your day. So, for example, if you're watching the news and it says, well, today there's an 80% chance of rain, you might think, oh gosh, I got to get ready for this day. I had a lunch planned outdoors. What am I going to do? I got to grab my rain jacket. I got to grab my umbrella. I may even grab my rain boots, and I'm calling my friend because no way are we going to be able to have lunch now outdoors because the risk is high to potentially rain. Now, on the reverse, if you watch the news and it said, oh, there's a 10% chance of rain today, you might say, okay, 10% chance that it might rain, 90% chance that it might not. So I'm just going to grab my umbrella, but we're still going to plan to have lunch outdoors. So you can see how we all interpret risk based on what we think might happen and then how we prepare. But what's important to keep in mind, risk is not absolute. How many of us have watched the news and it says it's a 10% chance of rain, and we just grab the umbrella and decide to go have lunch outdoors, and we're getting ready to leave, and we get into the car and the raindrops start to fall. So we know that sometimes even though risk is low, still things can happen. And then it's important to point out we all have different perceptions of risk. And I put a picture of an airplane up here because I think it's one of my friends that kind of always puts this in my ear that she doesn't want to fly because she's afraid of the risk of crashing. And you may not really realize this, but that risk is definitely much smaller, especially in regard to the fact that we drive every day and we're more likely to get in a car accident than we are to actually be in a plane that might crash. But her perception is that that risk is greater, and so she refuses to fly. But overall, like the rain example, risk assessment helps us plan. And that's what gene expression profiling allows us to do. It helps us plan. So if I have a patient, for example, that has a low risk score with a 31 gene expression profile test, it may change how I manage them. For that patient, sometimes I'm the only one that's taking care of them because they have a low risk of spread or metastasis. For some of my patients, for example, one that might go on to get a sentinel lymph node biopsy, if that comes back negative, yet they have a high risk score with the 31 gene expression profile test, or what we like to call 2B, I actually might manage them more aggressively. In fact, I might actually look to my medical oncology colleagues to help, or my surgical oncology colleagues to help watch them more closely. And I'm going to give you a case example as to how that actually happens and show you how management changes for the patient. But just like on a potentially rainy day, we modify what we're going to do and we prepare. Gene expression profiling can help us in the same way for our melanoma patients. So when we think about gene expression profiling for melanoma, why? I've kind of sort of set the background for this. Well, one of the things to point out that's very important is that the majority of melanoma deaths, around 60%, actually occur in early stage disease. So if you stop and you kind of think about that for a while, why is that important? Well, it tells us that we are actually misidentifying many high-risk tumors as low risk at the time of diagnosis. Again, we touched on staging before. Staging is essential for how we manage our melanoma patients. We put melanoma patients into groups based on common behaviors that then help us decide how we're going to manage and treat them. And associated with that, we then get a prediction of what potentially their survival may be. But again, the staging, it misses the individual patient, the outliers, potentially the bad actors that aren't going to behave like their staging says they should. And we can see that. We know that's an issue because the majority of those melanoma deaths occur in those early stage patients. So we really need to get better. We need to improve our prognostic accuracy. And if you think about it, staging currently doesn't take into account your individual tumor biology. And that's where gene expression profiling can be helpful to further define that. And it really allows us, again, to give that personalized approach to cancer care. That's the trend for all cancers. And now it's exciting to have it for melanoma as well. Now, gene expression profile tests for melanoma, there are different ones that are available. There's a 31 gene expression profile test that I've been mentioning throughout the presentation. There's also the Merlin assay and the Peregrine that is soon to come. Today, what I'd like to do is use a case study to kind of end our conversation with the 31 gene expression profile test to kind of bring everything home. This case study is a 34-year-old female with melanoma, and this patient actually has melanoma that is on the right arm. The Breslow depth is 0.6 millimeters, and then you can see here other features that are listed. These are the important things that we see as clinicians on your melanoma report that give us an idea of potential risk in our mindset and also help with staging. But if you kind of go all the way to the bottom, her stage by the American Joint Commission on Cancer is a stage 1A. So she's an early stage patient. So this patient, in our office, if we saw her, we would recommend having surgery to effectively treat her melanoma. Now, the thought was, well, let's take a look at her melanoma. Let's get additional information and order the 31 gene expression profile test and see, do we think her melanoma is going to behave similar to like we think of for a stage 1A, or will we be a little bit more concerned that her melanoma might potentially be more aggressive? Her result came back a high risk or a class 2B with the 31 gene expression profile test. That would suggest that she has a higher risk of spread or metastasis than what her staging potentially says that she will have. And so this is important because it gives us more information to kind of put a complete picture together. And the thought is, okay, I know that she's high risk. What do I do next? What would I do to change things for this patient? Well, in this case study, this patient did have a change in management. This patient was actually referred to medical oncology, and they underwent imaging. Their baseline imaging was normal, but repeat scans that they had later on actually showed a metastasis or spread of the melanoma to her lung. As a result, the patient was started on combination therapy, and at 48 months, she actually had clear scans. So this case is an interesting one because in the beginning, as you may remember, traditionally, this case would just be treated by excision. And the patient typically might see me or a colleague of mine in dermatology where we might do skin checks, lymph node checks with them, ask questions when they come in about how they've been feeling. We would also teach the patient to do their own skin check, lymph node checks, and also check their scar site and alert us if they thought that there was any recurrence or concerns. Now, the reality is there was a potential, issue with that follow-up from the standpoint that we might have missed the spread that this patient had. This went to her lung, and often this can go early enough where the patient isn't even symptomatic. So this was a big change where normally we just might follow this patient in the office, but in this instance, we actually looked to medical oncology for help. Imaging was used and an early spread was detected. The patient was started on combination therapy, and now she's doing well. So this is kind of a complete change from how we traditionally might have managed this patient based on the fact that she was a high risk with her gene expression profiling. Now, a lot of people ask me, well, what if she was a low risk? What would have happened then? If she was a low risk, because her risk would be exceptionally low for spread or metastasis, typically we would have followed her only with dermatology in our clinics. But because of that high risk, we looked to our colleagues to do additional workup and management. So her plan was completely changed. And as you can see here, with her clear scans, her outcome has been good so far. So this is an illustration how gene expression profiling, bringing everything home, is changing how we manage our melanoma patients. So in summary for today, I want to let you know this has been kind of a great way to bring gene expression profiling to you as melanoma patients, family, friends, or even loved ones of melanoma patients to kind of show you the role that it may play for us in melanoma. As you can see, there's a need for it. We need to improve our prognostic accuracy or our ability to really tell you what is your melanoma going to potentially do or how it will potentially behave. And it really helps define it where it's customized or tailored to you, like we illustrated in the example of M. Taylor, and also with the Lions. It helps with that biologic behavior. And I always like to use my toddler as an example too. When she wakes up in the morning, I don't know if it's going to be a day full of tantrums or if it's going to be a day of smiles and just giggles. And sometimes it's a day of both. But if I had a way to predict that, I'd love to know, because I'd probably, if she was going to be a day full of tantrums, I'd put her with my husband and I might take off and do some shopping. But gene expression profiling helps us with that now. It can help further define that melanoma and help predict what that potential, biologic behavior might behave. And finally, as you have seen, it helps us in how we manage our patients, and it's truly changing that management for us, and it's a valuable tool. I'd like to thank you again for being with me here today, and I enjoyed having this conversation with you, and I look forward to answering any questions.
Thank you so much, Dr. Trotter. You made this very daunting topic really easy to understand, and I don't think that that's something that many people can do. So thank you. It was just amazing, and I loved all of your analogies from the coffee shop, especially. I love have like one of those weird coffee, like I can't have this milk and I can't have that. So I loved how you were able to make it very applicable in our everyday lives. And then the genes, I think, was just such a perfect analogy as well, to really understand how gene profiling can be that customizable. With that, I was hoping I could just start with a couple questions, and then kind of going back to your analogy, thinking of the lioness. What do you do with those high-risk patients? So the ones that have that attacking, angry lioness.
Mm-hmm. So it's kind of interesting. It does depend. I always tell my patients on sort of what the initial plan is based on standard of care for your melanoma. So based on standard of care, if the recommendation would be to do an excision and you have a high risk patient come back with that result, after excision is completed, as a dermatologist, we might manage them more closely with skin exams. And then also in the example that you've seen, we may refer them on to medical or surgical oncology. In my practice specifically, we tend to work with surgical oncology more closely, and those high-risk patients will receive imaging typically at different intervals. Usually it's every 6 months, but they're monitored closely and there's multidisciplinary care. And then for the patients that a sentinel node biopsy is typically recommended, we may also, again, work with our colleagues to refer them for that conversation. If they go forward with that conversation and they wind up being high risk and their sentinel node biopsy is positive, then they traditionally follow our guidelines for further treatment. If the sentinel node biopsy is negative and they come back to us and they have a high risk result, again, they may be following with us, but also surgical oncology where imaging may be done as well. So I think imaging is probably the biggest change that we've seen in management of patients, especially while they're asymptomatic. And my surgical oncology colleagues I work with feel very confident in that to use as sort of monitoring or surveillance for those high risk patients.
Okay. And then kind of building off that, when is gene expression profiling typically done on a melanoma?
So a lot of people ask me that. They say, well, will it be done when my melanoma is treated, or how does it even happen? And so it's a conversation I usually have with my patients after I get their melanoma diagnosis back. So it's usually on the biopsy. So the skin that we remove for the biopsy to confirm the melanoma diagnosis, that is the tissue that we then talk with the dermatopathology lab to get and then send off for gene expression profile testing. So it's done early in the management of melanoma.
Okay, wonderful. And then I just have a third question, if that's okay. So when you were talking about, and you used the airplane as like a perfect analogy, and how everyone's journey is different in regards to melanoma. So when patients get the test and then they find out, this is what I am, and some people get really excited and some people are kind of bummed out. Can you just, I think, go into how, again, and reiterate how not everyone's journey is going to be exact. It's not, here's your script and go with it. Everything is different. Do you mind just kind of explaining that a little bit more?
Sure. I think what is, when you get staged, and people go online right away and look up their stage and they're like, oh my gosh, this is what it says. This is going to happen to me because I'm a stage 2B or I'm a stage, 1A. I tell my patients, yes, but let's look at actually your melanoma and see what is the gene expression? What does it really tell us? And again, if they're a low risk patient, that's kind of where we tailor it and maybe do less monitoring or surveillance where we may not have to follow them as closely. And then if they're a high risk patient, then again, we may actually follow them more closely. I think too that for patients that are high risk, the benefit has been, where a lot of people I think are concerned about Are we causing undue anxiety or stress for those patients? In actuality, I haven't found that. I feel like patients actually want that information. That information's been power. I would never recommend not doing a sentinel node biopsy for the fear that it might be negative, because that might harm a patient to go through that. And I feel very, very similar to gene expression profiling. Even if it winds up being negative, there's a value, or low risk, I should say. There's a value to have that done because that information is power. And if it's high risk, for those patients, it's also been powerful as well. And then, I think we really want to find out from patients to find out, what do they think, about that kind of risk assessment, so in their mindset, they know it's really about them and their not and their melanoma, and they're not just put into a broad category, that one size fits all.
That's perfect. That was just like the perfect answer. Well, I want to thank you again for your time. This concludes our third Ask the Expert session, once again partnering with Castle Biosciences. And if you're looking for more resources, please visit the MRF's educational resource page at melanoma.org. Our final session will take place next Tuesday, April 27th at 3 p.m. Eastern, right here on Facebook Live. In our final session, we will hear a presentation from Dr. Stephen Trotter, Assistant Professor of Clinical Surgery and Surgical Oncology at Clemson University on the Surgical Oncology team with the Greenville Health System. He'll be discussing the Lifetime Clinic for high-risk melanoma patients. Thank you, Dr. Trotter, for your time, your presentation, your wonderful analogies, and your expertise. We're just so appreciative. And we hope that everyone can join us again next Tuesday. So have a wonderful rest of your afternoon.